Hi guys, welcome to another video. In this video, we're going to be talking about alveolar diseases. So the first alveolar disease we're going to talk about is exudative phase diffuse alveolar damage. So just like the name sounds, you're going to see exudate, right? Exudate, you think something is coming out, so that's going to maybe lead to edema. So you already know, exudative phase, something's going to come out, it's going to lead to edema, diffuse alveolar damage, and we know it's just like very diffuse, and we have alveolar damage. So name tells us a lot in this case, and what you guys need to know is what's going on over here. So we have something that's causing injury to the alveoli, that's causing this diffuse alveolar damage, and that injury can be due to an airway insult or some blood insult. So types of things that can cause airway insults, such as smoke, infection, something that you aspirated, some things that can cause blood insults is going to be sepsis, drugs, shock, and some burns as well. So those insults are together going to cause some form of alveolar and capillary damage that's going to lead to things coming out of the capillary and the alveoli, and that's obviously if things are coming out, say protein is coming out, then water is going to be attracted to that area, and that's going to cause edema. And so that's actually a characteristic for exudative phase diffuse alveolar damage. The first 2 weeks after the injury, you see edema, and then you see fibrin hyaline membrane formation. And then so we have damage to the alveoli, we have damage to the type 2 cells as well, because the alveoli are lined by type 2 cells. Type 2 pneumocytes, if you guys remember, secrete surfactant, produce surfactant, and surfactant helps keep our alveoli, intact. They prevent collapse. They help us with the surface tension. They prevent alveolar collapse, basically. And if we are causing injury to the alveoli, then that means the type 2 cells are also being injured. And as a result, we see type 2 hyperplasia in this exudative phase diffuse alveolar damage. So clinically, what we would see in a chest x-ray is just diffuse alveolar filling pattern with air bronchograms. And the reason we see this diffuse alveolar filling pattern is because of that edema and then hyaline membrane formation. So the alveoli are being lined by these fibrin-rich hyaline membranes and just edema and whatnot. In the interstitium, you see edema and whatnot. And you can see in the picture here, just that labeled the alveolar filling pattern with the air bronchograms. And then if you look at the histological image, you're going to see that fibrin-rich hyaline membrane and edema. And clinically, what you're going to see is a patient is going to come in with acute dyspnea, hypoxemia, and decreased lung compliance. And if you think back to the pathology of this exudative phase diffuse alveolar damage, that actually makes sense. If you have fibrin-rich hyaline membranes in your alveoli, and if you have edema, then you're going to have a hard time breathing. You're going to have a hard time, passing that oxygen on to the capillary, because you have that interstitium that's filled with edema and just that fibrin in the way of, the oxygen getting into the capillary. So you're going to see dyspnea, hypoxemia as a result, because there's increased diffusion barrier, and decreased lung compliance because the alveoli is injured and it's not able to be as compliant and be as open to gas exchange and whatnot. Alright, so now we're going to go on to discuss the respiratory distress syndrome of newborns, and these are just particularly affecting the premature babies because surfactant begins to be produced during the 24th gestational week, and say you have a premature baby who is being born the 22nd week, they haven't even had surfactant being produced in their body. So this is going to be very, very very common in those premature babies. And even so, surfactant begins to be produced during the 24th week, but it isn't actually like the actual surge of surfactant is during the 32nd and the 34th week, because the baby and the mother begins to secrete cortisol, and the cortisol kind of primes more production of the surfactant because it's telling the baby, hey, it's almost time to go out into the real world and breathe on your own. So let's make more surfactant and make you strong and healthy to breathe on your own in the real world. So if you haven't even reached the 32nd or the 34th week, then you haven't even had that surge of surfactant production and whatnot. But surfactant begins to be produced during the 24th week, and then just remember that cortisol and all of those hormones are going to help us secrete produce more surfactant, and helps lung development during the 32nd and 34th week. So respiratory distress syndrome of newborns is going to be primarily in the premature babies because of insufficient surfactant production by type 2 pneumocytes. And so as a result, if you don't have enough surfactant produced, then you're going to see atelectasis. The alveoli are going to collapse. Atelectasis is just alveoli collapsing. And they're collapsing because they don't have the surfactant to keep the surface tension low, right? And if the alveoli are collapsing, then you have hypoxia, you have acidosis. You can't have air exchange because the alveoli are just collapsed, and the newborns are having to work extra hard to keep them open. And like as soon as you breathe out, the alveoli collapse, and to make them inflate again, that's just super hard work on the child, and the work of breathing has sufficiently increased because there is insufficient surfactant in the alveoli. So because of the hypoxia and acidosis, you're going to see epithelial necrosis as well. So clinically, you're just going to see diffuse intraalveolar hyaline membrane formation. Just like in the exudative phase diffuse alveolar damage we discussed earlier, you're going to see that diffuse intraalveolar hyaline membrane formation because of the epithelial necrosis and insufficient surfactant. And in the chest X-ray, if you conduct one, which is probably not as likely because the child is very young. I don't think we do that quite commonly, but you're going to see diffuse alveolar filling pattern with air bronchograms in the chest X-ray as well. And so clinically, the patient would be premature. The patient would be have tachypnea, very high respiratory rate, and they're going to have intercostal muscle retraction, and they're going to be hypoxemic as well. So that's respiratory distress syndrome of newborns. Alright guys, so next we're going to go on to discuss aspiration. Aspiration, you could aspirate gastric acid, and that would cause a diffuse alveolar damage. If you aspirate something that's foreign and exogenous, some form of exogenous material, that would cause a giant cell reaction, and giant cells are just a bunch of macrophages fused together. And just to note that children are more prone to aspirating foreign bodies and exogenous material, and adults are more prone to aspirating gastric acid and food and stuff like that. So say you aspirated a piece of steak or piece of meat or whatever you were eating, you're going to have you're going to see lipid like material in your histological pattern. Is going to be blobs of fat, blobs of cooked fat. That's what you see over here in this picture. And radiologically, you're going to have a very focal pattern, and typically it's going to affect the right lower lobe because the right mainstem bronchus has a larger caliber and it is more vertically oriented than the left mainstem bronchus. So you're more prone to aspirating whatever you're aspirating into the right lower lobe, consolidated into the right lower lobe than the left lower lobe. But all of this just depends on your patient's position and gravity as well. So in alcoholics, if they're in the prone position, they are more likely to aspirate into the right upper lobe because they're in that prone position. So it depends on a lot of things, but aspiration normally is going to affect the right lower lobe for two reasons. Number one being that the right mainstem bronchus is more vertically oriented than the left mainstem bronchus, and the right mainstem bronchus also has a larger caliber than the left mainstem bronchus. And exogenous lipoid pneumonia, which is a subset of aspiration, is most commonly due to something that you inhale that has some form of mineral oil or some like lipid material in it. So say you put some nasal drops into your nose and you accidentally aspirated it into your lungs, and that had some like fraction of it had some lipids in it. So that would cause exogenous lipoid pneumonia. And the best thing to do in that case would be just to switch over to a water-soluble nasal drop or water-soluble laxative or whatever you were using. So that's exogenous lipoid pneumonia. Exogenous lipoid pneumonia can also be a result of being on drugs such as amiodarone is known to be one of the biggest causes. So now we're going to go on to talk about endogenous lipoid pneumonia. So we just finished talking about exogenous lipoid pneumonia, which was most likely due to mineral oil aspiration. And in this case, endogenous lipoid pneumonia is most likely due to you inhaling some form of animal fat or a bronchial tumor that is nearby. Endogenous lipoid pneumonia is also known as post-obstructive pneumonia. It is also known as golden pneumonia. So post-obstructive pneumonia, as the name suggests, you're going to have central major airway obstruction. Okay, you're going to have a major airway obstruction, and distal to that airway, you're going to have a lot of, if you have a major airway obstruction, then distal to that, there's going to be a lot of damage, right? So if you see damage, you're going to have alveolar damage, and alveolar also have cholesterol in them. So cholesterol is just going to be accumulating, and you're going to see all these cholesterol clefts, and so the alveolar are destroyed, and you have these cholesterols, and the macrophages are trying to come to the rescue to help out with whatever is going on. And the macrophages try to digest those cholesterols and actually end up not being able to digest them as well. The macrophages are not able to digest the cholesterol as well, and that leads to the macrophages just being fat and foamy, and that is what you see histologically in the endogenous lipoid pneumonia. Histologically, you're just going to see foamy macrophages accumulation in the alveolar spaces. And it is because of that central major airway obstruction that led to the alveolar damage and the cholesterol being accumulated into cholesterol clefts, and the macrophages trying to eat them in, but they're not able to as well, so that just leads to foamy alveolar macrophages. Radiologically, you're actually not going to see as much radiologically, so what you're going to do is you're going to try to get a biopsy and try to see it histologically, and after identifying that foamy macrophage, and then peripherally, if you're able to see those infiltrates with that central mass, then that will help you confirm the diagnosis for endogenous lipoid pneumonia, also known as post-obstructive or golden pneumonia. So next, we are going to go on to discuss pulmonary edema. Pulmonary edema, the pathology behind that is just transudate from the interstitium and alveolar spaces from the capillary walls. And you're going to see capillary congestion. So how would you get capillary congestion? If you have a lot of fluid in the capillary, if you have so how are you going to get a lot of fluid in the capillary, you ask? It's going to be due to left ventricular pump failure. If the pump is not functioning as effectively, then you may have backflow of the fluid and blood into the capillary, and that's going to lead to capillary congestion. Or you could have mitral stenosis, the mitral valve isn't even opening as well, and that's going to lead to capillary congestion as well. So if you have capillary congestion, there's too much water, the hydrostatic pressure is too high, and that's going to lead to the outflow of that pressure out into the interstitium and the alveolar spaces as well, and hence you have transudate into the interstitium and alveolar spaces. So clinically, it's just free water in the interstitium and or the alveoli, possibly due to left ventricular pump failure or mitral stenosis, or you could just have the imbalance of the oncotic and the hydrostatic pressures from a variety of causes, and that would lead to edema and pulmonary edema as a result. So radiologically, you're just going to see increased vascular markings in pulmonary edema, and you may see reticular and or nodular patterns in the chest x-ray. Reticular, how I remember it, is just reticular is just lines in the chest x-ray. Nodular is just dots in the chest x-ray. So you could just have a lot of lines, or you could have a lot of dots, or you could have both, reticular nodular pattern, both lines and dots, and that's just going to indicate that you have pulmonary edema. Histologically, you're going to see transudate in the interstitium and alveolar spaces, and you're going to see capillary congestion. In this picture, you see that the transudate is pinkish colored, and possibly just due to blood coming out as well. But that's the reason for that, and you see capillary congestion as well. And that picture is just depicting a severe pulmonary edema. So next, we're going to go on to discuss some alveolar hemorrhage syndromes, and I'm going to go a little bit deviate from the chart over here and just go from Goodpasture syndrome to granulomatous polyangiitis, and then to acute lupus pneumonitis. So if you guys are following along on the chart, I'll be going in that order instead. Sorry for the chart being a little bit off from how I wanted to discuss this. So first, we'll talk about Goodpasture syndrome. Goodpasture syndrome, basically think glomerular nephritis plus pulmonary hemorrhage, okay? And glomerulonephritis is just several kidney diseases. It could refer to so many kidney diseases, and pulmonary hemorrhage in itself is self-explanatory. So what is Goodpasture syndrome? Goodpasture syndrome is a rare autoimmune disorder, particularly affecting young adults and males more than females. And how I remember that is when I think of a pasture, I think most predominantly males than females. So I remember that the males are more affected in this disease from this disease than females. And Goodpasture syndrome is when you have these anti-basement membrane IgG antibodies that damage your pulmonary and renal basement membrane. So you have these anti-basement membrane IgG antibodies that are targeting your own pulmonary and renal basement membranes. So now I remember I see pulmonary hemorrhage because I'm damaging my own basement membrane. I have these anti-basement membrane IgG antibodies that is damaging my own pulmonary system, and I have these anti-basement membrane IgG antibodies that is targeting my own renal system. So I have pulmonary hemorrhage and glomerulonephritis. So symptomatically, a patient is going to present to you with long-term a lot of symptoms because this is a rare autoimmune disease, and so it's going to take a long time to progress on as well. And you're going to see a patient who presents with massive hemoptysis, classically. Radiologically, you're going to see someone with diffuse alveolar pattern on the chest X-ray. And immunofluorescence, you're going to see linear IgG and complement deposition. And serum, if you were to check their serum levels, you're going to see anti-GBM IgG, which is anti-glomerular basement membrane IgG, which makes sense because we're going to see glomerulonephritis, and we're targeting our own renal basement membrane with these anti-basement membrane IgG antibodies that we have. And so if you were to do an autopsy of this patient, you would see that the lung is bright red or brown and reddish, and that's because we're targeting our pulmonary system, and you have this blood rushing out, so the red blood cells filling these alveolar spaces for that reason. Next, we're going to go on to discuss granulomatous polyangiitis, which is also formerly known as Wegener's granulomatosis. And this is a multi-system necrotizing granulomatous vasculitis, particularly affecting the small and medium-sized blood vessels. Patient is going to present with cough, hemoptysis, and pleuritis. You could radiologically have multifocal nodular infiltrates, which makes sense because you have these granulomas in multiple systems, right? So you see these multifocal nodular infiltrates in various systems. And if you were particularly concerned about alveolar hemorrhage syndrome, then you would check the lungs and you would see this multifocal nodular infiltrates in different areas of the lung. Immunofluorescence patterns are similar to glomerulonephritis. That's why I wanted to discuss this right after Goodpasture syndrome, because we remember that Goodpasture syndrome, we're targeting the renal basement membrane and leading up to glomerulonephritis, which is several kidney diseases. And we also see that in granulomatous polyangiitis, immunofluorescence pattern being similar to glomerulonephritis. So we're going to see these anti-GBM IgG as we saw in Goodpasture syndrome. We're going to see these anti-glomerular basement membrane IgGs. And we're also going to see ANCA-GN, which is just standing for abbreviation for anti-neutrophilic cytoplasmic antibody glomerulonephritis. So we have these, this is a rare autoimmune disorder as well, and we have this anti-neutrophilic cytoplasmic antibody because of these glomerulonephritis in the immunofluorescence pattern as well. And in serum, if you were to check their serum, you would see elevated C-ANCA levels, which stands for cytoplasmic anti-neutrophilic cytoplasmic antibody, and that's going to be seen not in all patients, but greater than 85% of the patients are going to present with elevated cytoplasmic anti-neutrophilic cytoplasmic antibody. And PR3 antigen is also commonly seen in these granulomatous polyangiitis patients. And the treatment for both Goodpasture syndrome and granulomatous polyangiitis is going to be immunosuppression. You're going to want to suppress their immune system to stop targeting their own, in Goodpasture syndrome, stop targeting their own pulmonary and renal basement membrane. Stop making all these granulomas in your multiple systems and, cause these nodular infiltrates. And we're going to administer cyclophosphamide and steroids and, try to do immune suppression. So next we're going to go on to talk about acute lupus pneumonitis. When I think of lupus, just remember, you guys, lupus commonly affects females more than males, okay? And lupus is also known as systemic lupus erythematosus, and acute lupus pneumonitis is just a component of the systemic lupus pneumonitis. And it doesn't particularly affect one age group versus the other. Seen in adults, children, any age group basically. Like I said, mostly affecting females more than males. You see diffuse alveolar pattern, and contrary to Goodpasture syndrome in acute lupus pneumonitis, you're going to see granular IgG and complement deposition. Okay, so think it's a systemic disorder. Lupus is a systemic disorder, unlike Goodpasture syndrome, which was particularly in the renal and the pulmonary system. So that was linear. In this case, it's acute lupus pneumonitis. Lupus is systemic, so you're going to think granular in all these systemic organs. And granular IgG and complement deposition for that reason. Pathologically, I'm not sure if that's the reason, but that's how I remember it. If it's systemic, then I'm going to see granular everywhere, all over the place. If it's, particularly in the renal and the pulmonary system, we're going to see linear. So that's how I'm remembering the immunofluorescence patterns. And in serum, acute lupus pneumonitis, you're going to see these anti-nuclear antibodies or anti-double-stranded DNA antibodies. And how I remember that is similar to how I remember the granular versus linear. Granular because it's in systemic organs, systematically affecting different organs, lupus is. And when I think of double-stranded DNA, everything mostly in our body has this double-stranded DNA. So if I have in serum these anti-double-stranded DNA antibodies, then it's most likely going to be affecting multiple systems in my body. And I think of lupus in that case. And anti-nuclear antibody, I just remember anti-double-stranded DNA, and then DNA, I just think ANA. So that's how I cluster that together in my brain to remember that in serum I'm going to see both anti-nuclear antibody and anti-double-stranded DNA antibody in acute lupus pneumonitis. So once again, just to summarize this alveolar hemorrhage syndrome a little bit more, I know it can be a lot of all over the place with memorizing immunofluorescence patterns and serum patterns and whatnot, and radiological patterns as well. So let's just discuss one more time radiologically what we're going to see in Goodpasture syndrome as well as acute lupus pneumonitis. You're just going to see diffuse alveolar pattern. However, in granulomatous polyangiitis, which is multiple granulomas in different organs, you're going to see multifocal nodular infiltrates, which makes sense because you're going to see granulomatous polyangiitis is going to affect systematically all these organs and form all these granulomas. It's just going to be in different organs. It's going to be multifocal, and you're going to have these nodules in different spaces. So that's how I remember that. Immunofluorescence pattern for Goodpasture syndrome is going to be linear because it's most likely just going to affect the pulmonary and the renal basement membrane with its anti-basement membrane IgG antibodies. And acute lupus pneumonitis, we're going to see mostly granular because it's systematic, and it's going to affect a lot of systems and organ systems, and you're going to see a granular IgG and complement deposition in that case. And acute lupus pneumonitis is also systemic, so I'm automatically going to think anti-double-stranded DNA, and DNA and ANA kind of go together, so I just think anti-nuclear antibody and anti-double-stranded DNA antibodies in serum. And in Goodpasture syndrome, I remember that it's targeting the renal and the pulmonary basement membranes, so I think glomerular basement membrane IgGs. And if I'm targeting that basement membrane, I'm getting all these blood out. So I'm going to have red blood cells filling those alveolar spaces, and histologically, I'm going to see the alveolar spaces being filled with red blood cells. And grossly, I'm going to see a lung that's like bloody and brown and red and whatnot. And granulomatous polyangiitis immunofluorescence patterns is going to be similar to glomerulonephritis, which we know Goodpasture syndrome is a combination of glomerulonephritis as well as pulmonary hemorrhage. So the immunofluorescence pattern for Goodpasture syndrome and granulomatous polyangiitis is going to be similar in the sense that they're both going to we're going to see anti-GBM IgG in both of these autoimmune diseases. And particularly in the granulomatous polyangiitis, we're also going to see anti-neutrophilic cytoplasmic antibody. And we're going to see an elevated cytoplasmic, anti-neutrophilic cytoplasmic antibody in 85% of these patients, and PR3 antigens in 85% of these patients as well. And the treatment for both Goodpasture syndrome and granulomatous polyangiitis, GG, is going to be cyclophosphamide and steroids, just trying to suppress the immune system. Alright guys, that was summary of all the alveolar diseases. I hope it was helpful. I will see you guys in the next video. Thank you guys.